So good afternoon, everyone. Thank you for the introduction. So I'm a postdoctoral fellow here in the addiction medicine unit. Okay. The presentation is based on the current available literature. There are no conflicts of interest. The slides can be produced wholly with due acknowledgement to Niman Seko. If there are any modifications required, please contact us on the following. So let us briefly go through these few of the interesting topics here. Let us start with the classification and roots of abuse. So to broadly classify psychostimulants, we have these broad four categories. The most important being the first two categories, cocaine and crack, freebase and the hydrochloride forms. Then the amphetamine type stimulants, we have mainly the three groups, the D-amphetamine, which street names being speed, uppers, and methamphetamine, chalk, glass, ice, and meth, and the methylphenidate, which is also used therapeutically. And the MDMA is basically a designer drug, which has a lot of so the third and the fourth category, of late we are seeing a lot of this surge in this cathinone group of drugs. The prototype being the mephedrones. The street names include drone, MCAT, meow meow, and bath salts, which of late has come into the market, and they are largely under the radar because in the current NDPS Act there is no legislature restriction of these drugs. And obviously the fourth group is very ubiquitous. I will not be dealing much into this. The methylxanthine group, the adenosine receptor antagonist, the prototype being the caffeine group. So let me start with cocaine. It's basically an alkaloid from the erythroxylon coca. It is indigenous to Western South America. Coca leaves are used for religious, mystical, and social, and as a stimulant and medicinal purposes. If you go through history, you will find that it was in the 9th century, the Incan Empire largely was noted to use these coca leaves, and it was given to laborers and the messengers who would do hard labor, and it was used as kind of a contingency for them. At the end of the day, they were paid with coca leaves, and gives us a sense of endurance, feeling of well-being, and also elevates hunger. The So if you go through the history, there are various routes of use. Oral ingestion was the major route of use till about 19th century. There is the circle mark that I have put is the major changes that happened in the history, that if we from the coca leaves to the current form of the crack. Let me briefly take you through some of those interesting history. In 1885, probably Pemberton launched his French wine coca, which was in fact advertised as an intellectual beverage, invigorator of the brain, and whatnot. And it was later renamed as Coca-Cola, which had the derivatives from the coca plant. And you can see from this slide probably how accepted cocaine was at that point of time. It was even used in children to cure toothaches, and it was all over the place in the pharmaceutical. They're all available in all druggists. They promised instantaneous cure for asthma, mountain sickness, seasickness, and whatnot. Only in the last years of the 19th century, there was literature began clear warnings about the psychoactive properties of cocaine. So coca paste is the most the first form, which is extracted and soaked with mashed leaves, has about 60 to 80% of cocaine. Cocaine powder made by mixing paste with hydrochloride acid, cocaine hydrochloride. And the last and important form is the freebase or the crack, which is extracted from the powder with baking soda until the water evaporates and produces a crackling sound, and hence the name. So the coca chewed leaves have a very low concentration. They are made into paste, which has about 60 to 80% concentration. The chemical extraction gives a purest form of cocaine hydrochloride, which can be snorted, which can be injected IV. Typically, one line of cocaine has about 25 mg of cocaine active ingredient, It is water soluble and it decomposes with heat, and hence it cannot be smoked. So there is this reverse extraction, which gives rise to these two alternate forms, which can be smoked: freebase and the crack form. They are highly concentrated. They are not water soluble, hence cannot be injected IV. They are heat tolerant and hence can be smoked. And usually, one dose of crack can vary anywhere between 250 to 1000 mg. This is a typical crack or meth pipe, wherein you have the area where you can heat it with a cigarette lighter, and fumes pass through a water chamber, and then it is finally inhaled. This is the other form of use, wherein you have aluminum or tin foil, wherein the powder or the crack is put, and it is heated from below, and this smoke is inhaled. So let's come to amphetamine, the other important group. It is also popularly called poor man's cocaine, crystal meth, ice, glass, and speed. It is a synthetic analog of ephedrine, which is an active ingredient. It has been in the tradition in China, wherein the yellow hemp contained ephedrine, and it is can be amphetamine is derived out of it. It was much popularized during the World War II, wherein as you can see from the picture below, wherein both the UK and the US gave the soldiers amphetamine for them to improve their concentration and ability to sustain and long durations of during the war. And also of late you can see in the subcontinent there are a lot of clandestine laboratories have come up, and it is called as yaba. The methamphetamine is called as yaba in Thailand, Laos, Burma, and Myanmar. In India, the methamphetamine in the northeastern part, it is called as bulbulia, and in the Philippines and Indonesia, it is called as shabu. Let me cut across half a century and come to 2014. There are not much there is absolutely no data on the Indian subcontinent about the stimulant use. So there was an exploratory study to assess the pattern of amphetamine type stimulant use in India, which was sponsored by UNODC. And though I could not get the full manuscript, it is clearly suggests that there is a huge concern in India, especially in the northeastern part of the country and in the metro cities, because of the easy availability of the precursor chemicals. Overall, as I was saying, the uses are reduced in the Europe and the American place, and due to the stringent law, but in the subcontinent it is still largely available. So this slide, probably the left hand side, you can see the chemical structure of amphetamine and the methamphetamine, which is very similar to dopamine and norepinephrine. I will go into much more details a little in the later slides. And this right half, you can see that ephedrine, which is a precursor molecule, can be easily converted to methamphetamine and the methcathinones. By reduction, we can get methamphetamine, and by oxidation, we can get methcathinones, the prototypical bath drugs or the MCAT kind of drugs. So currently, there is no much. The NDPS Act does not cover the precursors and the other amphetamine precursors molecules. However, coca cultivation is included in Section 16, and small quantity of cocaine use less than 2 gram, and the commercial quantity is 100 gram. Let me move on to phenomenology. It is a continuum of symptom severity ranging from cocaine euphoria to cocaine dysphoria to cocaine schizophreniform psychosis. So as we can see, there can be whole host of symptoms, and usually ranging from the intoxication to withdrawal symptoms and to induced psychotic phenomena. And also with the amphetamines, in the acute phase causes increase in alertness, decreased fatigue, self-confidence, exhilaration, and a sense of emotional communion, oneness, or relatedness, which gives its popular name called an empathogen for the amphetamines, and activation of sympathetic nervous system, improvement in overall task performance, which requires sustained attention, and also which require accurate muscle movement. And chronic use can cause a picture similar to psychosis with paranoid schizophrenia-like symptoms. Stereotyped behaviors are common: continuous chewing, grinding of teeth, rubbing of tongue inside the lips are seen in chronic cases, and in they also engage in repetitive thoughts or meaningless acts for hours together. They are preoccupied with own thoughts, process, and engage in grand philosophies. And the peripheral effects are mainly sympathomimetic: increase in blood pressure, increase in blood sugar, heart rate, irregular heartbeat, vasoconstriction, increased body temperature, bronchodilation, impaired breathing, and ventricular tachyarrhythmias in overdose. So coming to the tolerance withdrawal, physical and psychological dependence are known. Tolerance to euphoria, appetite suppression, sensitization to psychomotor activity are known. Withdrawal symptoms mainly classically described three phases. However, it does not actually encompass the whole host of withdrawal symptoms that the individuals go through. The phase of crash, wherein the hunger, fatigue, anxiety, irritability, depression, panic attacks are seen, followed by a phase of dysphoria or the classical withdrawal symptoms of the stimulants. This is 1 to 5 days after the crash, characterized by decreased activity, motivation, intense boredom, which may last about 1 to 10 weeks. And finally, a state of exhaustion characterized by anhedonia, which is probably because of the biogenic amine depletion, the complete depletion which happens in the synapse and the presynaptic neurons, and intense craving is seen. So let me move to the basic psychopharmacology. As I was saying, there are different routes of administration: snorted, IV, inhaled, and the oral form. The IV form, there is instantaneous peak that we observe from the graph, and also with the smoked form and the oral form, there is wider base, which the effects last for a longer duration. Both cocaine and amphetamine penetrate the blood-brain barrier easily. Cocaine has a half-life of about 50 to 90 minutes. Amphetamine is much more longer acting than cocaine, which has about 5 to 10 hours. And methamphetamine has about 12 hours of duration of half-life. The metabolites include both active and inactive compounds. Unusual about cocaine is it metabolizes, it has auto-metabolizing capacity in the blood in addition to the normal liver metabolism. The metabolites from cocaine are norcocaine, agonine methyl esters, and benzoyl agonine, which will help us in detection in the screening. We have immunoassays. The cocaine, the usual cutoff is 300 nanogram for cocaine and its metabolite benzoyl agonine. Use of cocaine for euphoria may result in positive variants in the last 2 to 3 days post the dose. Longer times will be observed in people habituated for larger quantities over longer period of time. Amphetamines, there are possibility of false positive, especially considering there are a lot of precursor molecule, ephedrine, phenylephrine, which can be used in the manufacture of amphetamines. And confirmatory tests can be done with gas chromatography and mass spectrometers. They as low as cutoff value of 150 nanogram can be detected. So there are a lot of adulterations of cocaine which is seen, especially the lidocaine, caffeine, hydroxyzine, and phenacetine, and other group of drugs. And also individuals use cocaine along with other concurrent or substitute use. Self-medication with sedatives to reduce the agitation and induce sleep, that is to come down after a phase of stimulant. Then cocaine used along with the heroin, classically called as speedball. And there are also other drugs which can interact with cocaine. The classical example would be of alcohol. Alcohol inhibits metabolism of cocaine. Alcohol with cocaine chemically reacts to form cocaethylene, which is newer psychoactive. It has its own psychoactive properties, which is similar to cocaine. It has greater cardiac toxicity, has about 3 to 5 times the half-life of cocaine, and has been known to be associated with seizures, liver damage, and compromised immune system. So let me move to pharmacodynamics. Cocaine is indirect agonist of DOPA, which is dopamine and norepinephrine, which has high affinity, and to modest affinity in the serotonergic system. Whereas MDMA is mainly serotonergic and less of dopamine and norepinephrine. Mechanism is the blockage of monoamine reuptake inhibitors. It's a reuptake inhibitor. The dopamine transporter, which takes the dopamine from the synapse back into the presynaptic neurons, are blocked, and hence there is more dopamine available in the synapse for the action. Compared to cocaine, amphetamine has much more stronger mechanism of action. It is classically described as a releaser. It inhibits vesicular storage in the presynaptic neuron. It causes rapid efflux of intravesicular monoamines from the perisynapse into the synapse. It also blocks monoamine reuptake, and whatever reuptake has happened, it also reverses the reuptake and makes more dopamine available in the synapse. And whatever dopamine is there, it also inhibits the MAO metabolism, so that dopamine is not metabolized. So as you can see, it is amphetamines are much more stronger acting and also has a more profound mechanisms of action. So moving one step ahead, there are mainly the dopamine is the key neurotransmitter, which is the reinforcement for the continuous use. The nucleus accumbens, which are reward center, and the hippocampus and amygdala, where the cue related to the cocaine use are stored, and also the frontal cortex inhibition is gradually impaired with the continuous use. Activation of D2 like receptors provokes cocaine use, whereas activation of D1 like receptors inhibits them. There are much more other mechanisms, because we know that drugs targeting dopamine system alone are not good enough in the treatment of cocaine addiction. So there are much other mechanisms which have been looked into, especially the glutamate system within the ventral tegmental area, and the nucleus accumbens appear to play an important role in the cocaine-induced reinstatement of a period of abstinence. GABA B and 5-HT2C receptors attenuate cocaine-induced reinstatement. There are other stress-based cues which increase stress levels, and the CRF1 receptor is particularly important, and probably CRF1 inhibitors may have a role in the treatment. So this is a very interesting. Let me go one step beyond the synapse and into the what happens after in the postsynaptic neurons and into the nucleus. So the classical stimulants increase dopamine in the synaptic terminal. Because there is increased dopamine in the synapse, there is increase in the cyclic AMP related activity happens in the postsynaptic neuron, which increases the phosphokinase A, which in turn activates the cyclic AMP related binding protein in the DNA, and causes increase in the transcription of a molecule called as delta phos B, which I think is one of a key molecule in the understanding of addiction, not just the cocaine addiction, in almost all forms of addiction. It is in fact called as a biomarker for addiction, and there is increase in delta phos B, which happens over the time, and delta phos B can stay in the neurons for months together, even after single use of. So probably this is one of the target which currently not.
Sorry, can you ask you to just keep your mics on mute for the duration? Just
So there are changes beyond the level of the synapse into the postsynaptic neurons. And also the cocaine amphetamine related transcript, the CART endogenous psychostimulant neuropeptide activated by cocaine administration suppresses the cocaine high, and the delta phos B that I was talking about, the increase in the delta phos B in the nucleus accumbens, probably a biomarker for addiction, and drugs targeting this system would be ideal. Currently there are no molecules which can target this. There are also genetic factors which have been identified, which may have been involved in the susceptibility to cocaine addiction, especially the dopamine receptor genes, dopamine beta hydroxylase genes, dopamine transmotors, and the dopamine phosphoprotein DARP32. So this is a summary slide for the neurobiology part of it and the pharmacodynamics. The cocaine has a shorter onset of action and peak within 15 to 20 minutes and lasts only for an hour, whereas amphetamines have a peak after 2 to 3 hours and lasts up to 12 hours. Cocaine is predominantly a blocker, whereas amphetamine is a releaser of the presynaptic monoamines. And
just one. I would request all of you to please keep your mics on mute and don't unmute yourself for the duration of the didactic part. If you do have questions, please send them in via chat. When the presentation ends, we'll give all of you an opportunity to ask your questions. Sorry, thank you. Go on.
So, causes comparative less stimulation of the nucleus accumbens compared to amphetamine. Let me go on to the evaluation and management part. There can be a few structured way of assessing cocaine dependence, there is this cocaine severity selective severity assessment scale, which is available. It is an 18-item instrument which can tap into the signs of cocaine intoxication as well as withdrawal. Domains measured include craving, depressed mood, appetite change, sleep disturbance, lethargy, pulse rate, and irritability. Let me move on to pharmacotherapy. Uh, Let me start off by saying there are currently no well-proven FDA-approved molecules for treatment of any of the stimulant dependence. So let me go into the individual goals that we might have in treating stimulant dependence. Treating intoxication would be one. Treating withdrawal symptoms. Relapse prevention would be the major chunk of it. Reducing craving, reduce the perception of euphoria with triggers, especially the priming dose when a relapse happens, environmental cues and stressors, reduce the brain exposure to ingested stimulant, either by increasing the metabolism. There are super cholinesterases that are have been tried, then preventing passage across the blood-brain barrier through some of the immunological mechanisms. Let me also talk about few vulnerability and some comorbidities. Intoxication is usually self-limited, typically requires only supportive care and specific treatment for hypertension, tachycardia, seizures, or any of the hallucinatory or persecutory experiences the one might go through. Acutely agitated patients might benefit from sedation with benzodiazepine. I'll not go into much of the details in the intoxication. Treating withdrawal, largely dopamine agonists have been tried. There are few open label trials which have shown efficacy, but however, largely there are no good molecules to treat withdrawal symptoms per se. Propranolol has been tried, which reduces peripheral markers of anxiety during the withdrawal and also might have some blunting effect on the cocaine induced euphoria during the craving. So there are a whole host of mechanisms which candidate molecules have been tried. Till date, there are no medication which have been found to have clear-cut efficacy. However, there are four or five important candidate molecules which I will be focusing. So these are the four group of drugs that I will probably brief upon. The agonist like replacement therapy, the amphetamines, the methylphenidate and the modafinil group of drugs, the glutamatergic, the N-acetylcysteine and the GABA glutamate action on the topiramate, and dopamine agents. I will explain why I have put disulfiram in the dopamine agents, immunotherapy and vaccine which are available. Let me start with the agonist like agonist substitution therapy. Uh, there is definitely evidence to suggest there is 6 times greater risk for developing substance use disorder among patients who have ADHD in childhood and have residual ADHD going on into the adulthood. They have early onset of symptoms, have more severe substance use comorbidities. The two main aspects of the self-medication hypothesis are that individuals use addictive drug to relieve them of their sufferings or distress, and there is considerable degree of psychopharmacological specificity in individuals' drug preferences. So, like in alcohol, people have tried to classify who are vulnerable for cocaine dependence, and there have been cocaine typologies, type A and type B. The type A is more environmental, and the type B is more genetic. There is equal gender distribution in type A, whereas there are more male affected in the type B kind of typology. Personality factors: there is low impulsivity, sensation seeking, high harm avoidance in the type A, whereas in the type B there is more impulsivity and sensation seeking. And also in the type B, we find there are a lot of childhood vulnerability factors in the form of conduct disorders and ADHD, which are very minimally seen in the type A group. Age of onset is typically earlier in type B, and the substance use severity is much more chronic, severe, and also polydrug in the type B. And also looking into psychopathology, there is higher severity of symptoms. There is more antisocial characteristic which can be found in the type B. This is a typical typology which have been described for cocaine. So going into this kind of vulnerability, let us go into agonist type of treatment which are available. Dopamine reuptake inhibitors have been found to be effective for dopamine releasers. That is, the blockers have been found to be effective for releasers for reducing use of dopamine release, and dopamine releasers are found effective for dopamine reuptake inhibitors for reducing use of dopamine reuptake inhibitors. The amphetamine isomers significantly reduce percentage of cocaine, but not amphetamine. Which is amphetamine is a typical example for the blocker that I described, and cocaine is a typical example for a releaser that I described. So amphetamine has been found to be useful in cocaine dependent individuals and not in the amphetamine dependent individuals. There are a lot of evidence to suggest that. They have quoted few of the references here. And methylphenidate, though it is a amphetamine type of stimulant, it is mainly a blocker like the cocaine, and hence has significantly reduced the percentage of amphetamine but not cocaine, and positive urine samples during the treatment in many of the double-blind placebo-controlled trials. The other molecule that I would like to talk in the agonist-like treatment is modafinil. Primarily, the primary effects include the inhibition of dopamine transporter to increase the extracellular levels of dopamine. It also has some effect on the D2-like receptors, activating them, and have some secondary effects including the inhibition of noradrenaline transporters, enhancement of 5-HT function, stimulation of glutamine and histamine release. All of these are typically seen deficient in the cocaine dependent individuals, and hence some therapy is suggested. There are randomized control trials which I would like to quote. In 2005, there was a double-blind pilot trial with 62 cocaine-dependent patients who received modafinil. They submitted more cocaine-free urine samples than the placebo. And in another study by the same group, over 16 weeks, two 10 cocaine-dependent individuals were taking either 200 mg of modafinil or 400 mg or a placebo. Among those who were dependent only on cocaine, the study also included other substance comorbidities, and they found people who were dependent only on cocaine, both dosage of modafinil were superior to placebo in promoting abstinence, which was not found if the person has more than one drug of abuse. So this very important review article, summarizes the recommendation for agonist-based treatment. For less severe stimulant dependence, probably modafinil, and also to some extent, I did not deal much about bupropion, but also there is some evidence to suggest bupropion also helps in low degree of severity of stimulant group. Moderate severity, methylphenidate and modafinil have some evidence, and in high severity of stimulant dependence, especially the D-amphetamine, the SR preparation, lisdexamfetamine, which is a prodrug which cannot be injected, and has a sustained duration of action, has been tried and has been found effective. Methamphetamine, especially in the sustained release preparation, has been found effective in patients who are severely dependent on these stimulants. The apart from the usual cause for concerns of diversion or abuse or the parental use, the cause of concern would be of cardiovascular, and the risk would be additive on relapse. So hence a baseline ECG, baseline and intermittent monitoring of the pulse and the blood pressure should be performed as with all the psychostimulant treatment. So after covering the agonist-like treatment, let me go into the dopamine agents like disulfiram. So from time immemorial, disulfiram has been used as a deterrent in alcohol dependence due to its function of inhibition of aldehyde dehydrogenase. It has also been found to inhibit dopamine beta hydroxylase, and one of its metabolites may influence the NMDA subtypes of glutamate receptor. And theoretically, hence, disulfiram may have a property of a functional dopamine agonist, at least, and a neuroprotectant. So let me go into this this article from the Nature Medicine. The action on the liver cell, the aldehyde dehydrogenase inhibition causes increase in the acetaldehyde. This we all know, and cause aversive reaction to alcohol. Let me bring your notice to the neuron on the right side, the norepinephrine neuron. There is inhibition of the dopamine beta hydroxylase by the disulfiram molecule, and there is increase in dopamine, so which might attenuate the cocaine relapse. There is increased dopamine available in the synapse, and hence there is a reduced need for dopamine like agents like the stimulants. Let me bring your notice to the dopamine neuron, which is on the left side. The aldehyde dehydrogenase type 2 enzyme is also inhibited by disulfiram, which probably inhibits the dihydrophenylacetaldehyde from converted to the acetic acid version of it. And because of which there is increase in level of dopal. And when the person uses cocaine, when the individual has a relapse, and there is a cocaine use dependent inhibitor is generated, which is the tetrahydropapaverin. And more the level of THP, the more the, reduction in the which is actually THP is actually a inhibitor for the tyrosine hydroxylase, which causes reduction in the dopamine level. So the more amount of cocaine is used, more amount of THP is generated, and more inhibition of the upstream pathways which lead on to produce dopamine. And hence disulfiram has been tried in stimulant dependence and has been found effective. So there are several randomized placebo-controlled trials which have at least demonstrated moderate effects on cocaine use, largely from the Carroll et al. Group, and also patients who have cocaine or with alcohol, with cocaine, with opium dependence. It has been found to have moderate effect size. However, in event of a relapse, cocaine and on cocaine or on alcohol, disulfiram may actually increase the cocaine plasma levels, and also the compound, the cardiovascular effect of the increased acetaldehyde because of the disulfiram inhibition. So after disulfiram, let me go to the glutamatergic and the GABAergic agents. Let me start with N-acetylcysteine. It has been used for decades as a mucolytic agent and an antidote for paracetamol poisoning, but it also appears to reverse the impaired cysteine glutamate exchange within the neurons and the glia. Since an intact cysteine glutamate exchange is needed to maintain normal extracellular level of glutamate, which may actually be low in the stimulant dependent individual, and hence a therapeutic effect is suggested. So there is a low baseline level of glutamate level, and when there is cocaine or amphetamine use, there is an amplified glutamate signal which happens due to the cocaine or the amphetamine use. And because of an amplified glutamate signal, there is a large amplified long-term potentiation that happens due to the cocaine associated reinforcement, and hence there is larger reinforcement, and the possibility of relapses are high. So possibly restoring the low basal glutamate levels may offset this series of events which happen, and possibly improve cortical baseline functioning and the neuropsych performance. So preclinical studies and early pilot clinical investigation with N-acetylcysteine have been promising, and there are several controlled trials which are happening as we speak. A 8-week double-blind randomized placebo-controlled trial with 111 cocaine-dependent individuals either receiving 1200 mg or 2400 mg of N-acetylcysteine. They found that 2400 mg group had longer time to relapse and longer craving and lower craving rating. Though the primary result of this study was negative, they did not find a difference between the placebo and in terms of the number of urine and cocaine negative urine samples which were given. After moving from the glutamate, let me take you to the topiramate molecule. It is complex and broad mechanism of action. It increases GABA A receptor signaling. It also decreases the glutamate signaling through kinase receptors, and also has some signaling and blockade of sodium and voltage gated calcium channels. It has a very high bioavailability and also has a longer half-life, 19 to 25 hours, which is very suitable to treat the chronically low level of GABA signaling which is found in the cocaine dependent individuals. So there are at least 5 trials I could find on topiramate. The first 3 are positive. A 13-week double-blind random placebo-controlled trial with 40 predominantly crack cocaine-dependent patients. Topiramate 200 mg was used as an adjunct to CBT and was found more effective in promoting sustained abstinence than placebo. In another 12-week trial with 142 cocaine-dependent individuals, it replicated this above study with a larger, higher dose of topiramate. And another study which used a combination of amphetamine, extended-release amphetamine salts with topiramate, found that also to be effective in cocaine-dependent individuals. So this study had both amphetamine salts and the topiramate which was given together. Another uncontrolled trial among 28 intranasal cocaine users receiving 300 mg of topiramate with counseling. The craving for cocaine significantly reduced, but they had only 25% of urine sample were negative. So the result was not. Result was only equivocal. And another recently concluded trial from Netherlands, they found topiramate neither improved treatment retention nor reduced cocaine or other substance use. So this is one of the negative studies which were published recently. This was part of the larger catch trial which was started in the Netherlands. So after moving from the glutamate GABA agent, let me take you to immunotherapy. What are the promising new treatment approaches which are available? Antibodies made against cocaine to break down the molecule and stop its effects have been tried. Currently, there is one phase 3 trial which has been completed in the US this year. They used a succinyl norcocaine conjugated, was conjugated to the cholera toxin B, which would generate antibodies. The immune systems would generate antibodies against both this cholera toxin B and the succinyl norcocaine. And the only difficulty they found with this approach, not every individual produced a sustained high levels of the antibody titers, and hence the response was different in different individuals. A full 16-week cocaine study was done, and the cocaine positive urine rates showed no significant difference between the three groups, which are placebo high and the low immunoglobulin group. So this was, even though it was initially very promising, there are several other phase 3 trials which are happening. This phase 3 trial was largely negative. So let me conclude by saying there are currently no medications approved by the FDA for the treatment of stimulant dependence. However, there are several promising candidates as we went through. Many of these medications have already shown promise in the double-blind randomized phase, and virtually all of them are undergoing confirmatory testing. Also, I would like to add that behavioral and psychosocial treatments may augment the efficacy of medication for treatment of stimulant dependence and are integral part of the treatment. So these are the four group of pharmacological agents that I discussed. Thank you.
Thanks, Bharath.
That's very nice.
So,
Just want to point out in terms of the topiramate study from the Netherlands, it was a lower dose. It was 200 milligrams a day, and just above it, the 300 milligrams a day was more positive. But the clinical guideline for using it in the United States is that it's really important to start at a low dose and build up.
Gotcha.
So if you don't give yourself time to do that, you're not going to get as good a result.
The cognitive side effects are mainly related to the rapidity of the dose escalation and also the tolerability issues.
any clarifications, questions?
Okay, we do have one question from Dr. GSP Raju. So how do you treat? In the light of all these recommendations, what do you do?
So as we were discussing initially, when I started my pharmacological management goals, the first and foremost would be to look at vulnerabilities and look at the residual or the adult ADHD symptoms. Clearly, there is evidence to suggest that agonist stimulant like agonist like treatment have been found effective in the type B kind of cocaine dependents who have higher
Yeah.
I just wanted a straw poll around the country as to how many people are now starting to see stimulant cases.
I
Because
guess
we
we'll have
have
to do it
a
visually.
country represented here. I just wanted to know how many people were starting to see, especially in the Northeast. Like,
Northeast.
Do people in Tezpur see stimulant cases?
This is a question from Dr. Vivek to the Tezpur team,
Not just Tezpur. I want to know whether
anybody in the country about
is actually treating.
treating stimulant dependence. Your personal experiences. on treating stimulant dependence?
What?
If anybody's perhaps had an experience with treating any client, even a single client, etc. Okay, we do have one answer from Dr. Saurav Das, who says that patients come, but they are mostly once or twice experimental users. That is, they're not regular users, but experimental users. I think that's something that's quite similar.
That's quite similar
to what we
profile
see
here.
overall.
No, but our
There are
profile is that you have people who are party users, which are
Party users.
and so we're starting to see people with severe long-term groups. I'm surprised that people in the Northeast are not getting it, because they share a common border with Burma and Bangladesh, where it's rampant.
I think there's a big problem in Nagaland, Mizoram, and that group. It is very difficult.
But I don't think they're making their way to treatment centers yet.
Yeah.
This is something that this is a major demographic challenge which is going to occur in the next couple of years.
Christina.
Yeah, the Yaba, Shaba, Shabu.
Shabu.
Bangladesh is full of Shabu.
We do have one question asking to know a little bit more about methadone and MCAT and managing patients with addiction to it.
So this is that the other group of drug that I was talking about, the methcatinones, which are actually also derived from the basic ephedrine molecule, and so the cathinone group of drugs. I think my colleagues from Mumbai or the other metros would be able to tell me that there was a lot of news coming up that there was a huge upsurge of this MCAT, largely because there is under the radar there are no legal restrictions on the methadone group of drugs, and also because it has been called as bath salts and other things. So transfer between sites, which have not largely.
One of the most famous names associated with this has actually been John McAfee, who's actually advocated the use of bath salts quite.
And I think these things are more of reports from popular media related things like, and I don't know how much it translates to clinically people seeing people with dependence and things like that. I'm not sure.
Well, bath salts are an emergency room problem in the United States, definitely. And the problem that we have is we declare something illegal, and almost immediately a single atom is changed in the compound, and we've got something else to declare illegal.
Would you like to give a brief overview of how do you treat? Yeah, I think we have not completed that. We get a stimulant dependence. How would we treat? Like, how would we like to go about the case? You finished?
For example, any idea about use of, say, TCAs in clients who had a crash, for example? What's the more literature?
Yeah, you didn't cover TCAs, did you?
TCAs,
Similar in action.
There are a lot of open label trials
Open label trials.
which have found, especially ameliorating the withdrawal phase, increasing the release of biogenic amines, and associated improvement in the mood state. But largely for dependence per se, there is no much evidence of any of the TCAs or the other antidepressant group, except for probably bupropion, which has some evidence in mild cocaine dependence. There is some data to suggest a dose of 300 mg per day has had some effect.
There's a question from Dr. Saradia about caffeine withdrawal in inmates of halfway homes, because it can be quite troublesome.
Inmates of institutions also.
On both sides of the table.
Both sides of
On both sides of the table.
I think the question here is why why is this occurring? Why aren't they providing coffee in that way? I just read in the Times of India this morning that caffeine is good for your heart.
Yeah, I think as Dr. Vivek is saying, that there is a caffeine withdrawal which is there across the table and here and there also. Like I'd like to add some information that to Dr. Muktesh, there are a lot of appreciation about your presentation is coming on the chat. I appreciate your effort that you worked up the case and you presented it for us. Like we encourage such kind of presentations in the future, like because if we keep presenting, it would become more of monotonous thing. Then we would like to hear different genres of cases, like from different perspectives, from neuropsychiatric perspectives also to be presented. Like, so we encourage others to present cases.
Plus, to be truly effective, we require people from different parts of the country, different centers, bringing up their experiences and everybody pitching in, and so that we can learn from each other. And I think today has been one of those days when we had quite a lot of discussion on something that happened. And because it was from the Northeast, there were certain things which were peculiar to the Northeast, which we all learned about. And thank you, everybody. I think it was a very enriching experience.
Thank you, Bharath. It was for I'd say it's a complete overview of first thing. Like you have made a chapter of stimulant dependence, which you can write up.
And I need to put it, write a review article.
Write a review article on that. Okay. Thank you very much. Thank you, everybody. We'll break for the day.
Thank you.
Thank you.
Bye-bye.